look at the ocular movements and look at the uniocular and binocular before you decide for any management of strabismus, especially surgery. And if you talk about the management, medical management of squint is very less depending upon the type of strabismus. If it's a partially accommodative squint, then you would think of glasses. If it's a paralytic squint with diplopia, temporarily you can treat them with fresnel prisms. But the ultimate management of strabismus will be only surgery. So the aim of surgery on extraocular muscles would be mainly to correct the misalignment and then to restore binocular single vision. And the idea of doing this surgery intends to change the extraocular muscle action mainly by you weaken them or you strengthen them or you modify their plane of action by transposing them. And not only the muscles, a lot of meticulous attention should be paid to the extraocular, periocular tissues, mainly the check ligaments, the fascia, the conjunctiva, etc. This is mainly to eliminate, create passive limitations of ocular movements. So the indications, why is surgery performed at all in these patients? One is to improve the function and also to improve the cosmesis. That's the main reason the patients come to you for cosmetic appearance, to release asthenopia, to eliminate diplopia and paralytic squints, to restore stereopsis, and then to correct abnormal head position, like especially nystagmus we're talking about, and also other superior oblique palsies and Duane's retraction syndrome and Brown's syndrome, and to improve visual acuity. So when you prepare these patients for surgery, the surgery itself is not technically very difficult. We all know that the muscle surgery, it's pure mathematics, the calculation. If you know how much to correct for what angle of deviation, so the surgery technique is not very difficult, but then the planning is very important in the sense that you plan meticulously, that the planning is not to correct the angle of deviation, but then to customize to each patient. A patient presenting with 45% diopter doesn't have 8/5 across, but then you have to decide what this patient needs appropriately and then treat accordingly. And then you need to have a complete knowledge of anatomy, the oculomotor physiology, and then certain preoperative diagnostic techniques will have to be done, and then what surgical resources you have. And another important factor is you're dealing with two types of patient. One, a very young child or a very middle-aged girl who's going to get married, or a very old patient. So these are the people you'll be dealing with, and then a lot of attention to the psychological aspects, because you have to reduce the anxiety of these patients and parents, of course. And then you need to explain to them details of surgery. You need to give them a chair time and counsel them appropriately so that they have to understand that sometimes the surgery is done only for cosmesis. When you have a patient with a sensory exotropia with poor vision, the surgery is only for cosmesis, and then again there's a chance of drifting. So you really have to sit and explain to them the risk of anesthesia, and then information about the goals, and very importantly second operation. Because not always strabismus can be corrected by a single operation. Most of the times you need a re-operation that has to be explained. Timing of surgery, again, it depends upon the type of squint. Like Arun was mentioning, it's a daytime emergency. When you deal with a child who presents with a sudden onset of esotropia, you have the risk of amblyopia and then suppression. So you have to, depending on the presentation of the squint, the timing can be planned. But otherwise, if it's done for cosmesis or other squints, then your timing can be planned. And then congenital esotropias can be operated as young as 3 months of age, or you can wait till the child is about 1 or 1.5 years of age. And again, it's very subjective and depends on individual. And age of the patient, and again, presence of various sensory adaptations can vary the timing of surgery. And the goals would be to establish what is the cause of strabismus. You should always keep in mind the pseudo-strabismus, because not all the strabismus you're seeing could be true. This child here, prominent epicandral folds, you have to keep in mind of that. And then it could be congenital or acquired, or if there's any other restrictive pathology associated. So you have to rule out if there's anything like that, and also assess the binocular motor and sensory status, very important, and then measure the deviation. So near and distance, very important, and if there's any underlying amblyopia, you have to diagnose and treat it. Again, different school of thought. Some people say that you have to treat the amblyopia and then go in for the strabismus surgery, which is good because sometimes you fix the strabismus and the parents are not bothered about it anymore. So the best thing would be treat the amblyopia and then plan for strabismus surgery. And preoperative evaluation is important. Detailed history regarding the onset of strabismus and the duration and how it presents. Is it present? Is it the same at all times and all dies? It could be even a myasthenia or even an intermittent exotropia. Then assessment of vision is very important. Refraction ocular motility examination, and I already mentioned about the amblyopia and sensory testing. And then restriction, AV pattern, always look for patterns. Sometimes if you have a or a V pattern, then you have to deal with the muscles in a different way. If there's any associated incompetence present, any previous surgery, which is very important, because you need to sometimes do imaging to find out where the muscles are present. And then if there's any associated postoperative diplopia, especially a paradoxical diplopia can be there, so you need to explain to the patient. And anatomical considerations, if it's again previous surgery, or sometimes we're dealing with small eyes or large eyes. Blood supply of the antral segment, again when you're dealing with an older patient with systemic diseases, sometimes you can end up in an antral segment ischemia, so that's very important. And development consideration, of course. And the special motor test would be the force duction test, the force generation, and the saccadic velocity. So this is the force duction test. The force duction test, the main idea is, can you click on the,
Excuse me.
yes, let's come. So just watch the video. So the force duction test, especially when you have a patient, this is a patient with the left sixth nerve palsy. Yeah, it's working now. So her adduction and abduction is normal, but you see here there's a limitation of abduction. So it's a sixth nerve paresis. So this force duction test mainly to differentiate between muscle weakness and a restrictive cause. And another important step would be the intraoperative. I have a picture of the force duction. I'm just trying to see if. So this can be done as an office procedure. Can be done as office procedure where you make the patient lie down. The video will just start. So it's a very helpful test whether to find out whether it is a paralytic squint or a restrictive squint. So you can do this force duction test. You can put anesthetic drops. Sometimes you can dip the cotton plug and place it over the conjunctiva to make the patient feel more comfortable. And use two forceps to pull the muscle out. The adduction is normal. So this is how you test for the force duction. Then the intraoperative force duction test, before starting a strabismus surgery, it's very important to do a force duction intraoperatively. That will help you to feel if there's any restriction. Sometimes if there's a positive force duction, then you have to change your plan of surgery or plan to do an adjustable suture and so on. The force generation test, again to strengthen to look if there's any function of the paralyzed muscle. So this again will help you to see whether operating on that muscle will have an effect or not. So this mainly to test the muscle function, the force generation test. And the saccadic velocity, again, is a test which will help you to ask the patient to look. You will get a close-up view now. Usually the rectus muscles are responsible for saccades. So the degree of saccades may be proportional to the extent of muscle thickness. The adduction is normal. You can make out that there is a floating movement in this patient with paralysis. In case of restriction, there will be an abrupt stop. You can see here. This is fine, but here there is a small floating. It is not abrupt. So this is a paresis. So that's the saccadic velocity test which will help you. And the Prism adaptation test, when you're dealing with patients where there is a possibility that the diffusion may be restored, and if the patient has diplopia, then this would help you to find out whether these patients are able to neutralize. You can measure the exact Prism amount, and also in case of small angles, you can have help you to determine the target angle, and also in acquired exotropia. So you can use the Fresnel prisms initially, or you can do Prism adaptation test to find out whether you help you to decide on the amount of deviation and the amount of surgery you're going to perform. Anesthesia, usually preferably, now we have done strabismus surgery at topical anesthesia, but preferably in local anesthesia, especially you have the risk of oculocardiac reflex. So always these patients can be done under good anesthesia with the monitoring of the the pulse and so on. It also, small children, it can be done general anesthesia, and especially when you're doing both eyes at the same time, general anesthesia preferred. Sutures, you use absorbable sutures, mainly a 6-0 vicryl for the muscles and an 8-0 vicryl for the conjunctiva. and you use non-absorbable suture when you're doing adjustables or muscle transpositions, or you're doing other fixation procedures for third nerve palsies. You can use a Mercilin or Dacron suture, and a saturated needle is and the most dreadful complication you would have in strabismus surgery is perforation. So you have to be very careful when you use the needle and how you hold it, etc. And the conjunctival incision, you have options available, a fornix or a limbal incision, again depending upon the type of squint you're dealing with. If it's a resurgery, you would need a good exposure, so a limbal incision is preferred, or sometimes you go in for the swan, which is on the muscle, and then you have now the small incision like we have in cataract. We have the minimal incision. You have the miss in strabismus surgery. And the types, I'm not going to the detail because it's committant and incommittant, which already has been dealt with. Choice of operation, you have a weakening procedure, strengthening procedure, or procedures which change the direction of the muscle. So weakening procedures, you have recessions, you have conventional recessions, where you loosen the muscle, produce a slack, and then the hangback in cases which you need to do larger recessions. And you have marginal myotomies and myectomies. Sometimes they do small myotomies even as an office procedure. Now Dr. Kenneth Wright has popularized this technique. Then you have posterior fixation suture. I'm not going to the details of these procedures. And the strengthening procedures, you have resection and tucking, kind of plication and advancements are other strengthening procedures. Now plication and tucking are becoming a little more popular than resection. So that's the strengthening procedure. The transposition, you transpose the vertical recti for A and B pattern. If there's if the pattern has an associated oblique overaction, then you will deal with the oblique muscles. If it is purely horizontal, then you can transpose the muscle either half tendon width or quarter tendon width or full tendon width, depending upon the angle of deviation, which differs from up gaze to down gaze and primary position. And then you have other transposition procedures, especially for sixth nerve palsy, and you have the Hummelsheims and Jensen's, and then other transpositions for Duane's retraction syndrome and so on. This is the A pattern deviation. The child here is an A esotropia and an A exotropia. This is a V esotropia and a V exotropia. If there's so again you have to decide if the inferior obliques or the superior obliques are overacting, you deal them. Otherwise, you would go in for a transposition of the horizontal recti. Esotropia, again depending upon the type of deviation, you would either do one eye, but then you have to be cautious in that sometimes when you operate on one eye, it can cause incompetence. So a bilateral surgery is preferred. Again, it's the surgeon's choice. You would do either a bimedial recession or you would do a recess resect in one eye only and plan for the other eye later on. If there's an associated DVD, then again you plan recession or anteposition depending upon the amount of dissociate vertical deviation. Exotropia could be constant or intermittent, and in exotropia, it is the one thing you have to keep in mind is if it's a child, when you're operating on intermittent exotropia, it's very important that you should not cause a consecutive esotropia. So that is again one thing you have to keep in mind. So the angle of deviation should be measured for distance, and then you can do a patch test to get the exact amount of deviation, which will help you to plan your the surgical numbers. Again, the numbers, if you operate the medial rectus, it again differs from surgeon to surgeon. Ideally, each millimeter up to up to 5 millimeter will correct 2.5 prism diopters for the horizontal recti, and 6 and 7 will correct about 3 prism diopters, and so on. And 10 millimeter corrects about 5 prism diopters, and the vertical recti each millimeter will correct about 3 prism diopters. So you have to know the table, and again each book gives a different table, so you need to follow, and which is good in your hands, you have to follow that table. And for repeat muscle surgery, force action text is mandatory, and you need a good exposure of the muscles to be operated. And adjustable suture technique is a very comfortable technique, wherein when you're doing resurgeries or when you're having small angle strabismus, variable angles, or patients with diplopia, you can always use an adjustable suture technique. So you see this child here presents to you at the age of 4 with the esotropia, operated, remains orthophoric when he was 15, and then comes back to you at the age of 24 years with a consecutive exodeviation. So these are the patients. This is what I said, that you need to explain to the patient that we do not know who will go in for reoperation. So these are patients where you would want to do a surgery. Again, you would do a medial rectus advancement and a lateral rectus recession, and this preferably under adjustable suture. So, and studies have shown that there is 33% probability of yet another surgery in these patients. So adjustable suture is already mentioned, mainly for small variable deviations and restrictive strabismus, especially when you're dealing with thyroid or blowout fractures, etc. Re-surgeries and concomitant surgeries with diplopia. This child here presented reso, operated immediately, had an exo. Again, another thing which can cause this is a child operated for ESO, presenting like this. Pardon? Muscle slip, yes. Maggie and I were classmates, so probably Maggie felt the same thing. Yeah, muscle slip and lost muscle can cause this immediately. So this is the adjustable suture. You have different techniques. You have the sliding nose technique and other techniques. So that's for this. And again, strabismus is refractive error. You can. It's always better to measure them with contact lenses, or you have this formula which you can follow. With this, the factors influencing surgical results would be the age at which the patient presents to you, the type of strabismus you're dealing with, and the magnitude of deviation. If it's a larger deviation, you may have to do both days, or you have to do a second sitting. And you have to keep in mind the AC by A ratio. The quality of fusion reflects amblyopia, like already mentioned, has to be treated first. The underlying refraction. Sometimes there may be certain neurological lesions, and sometimes it's central fusion disruption where the diplopia cannot be corrected even after surgery. So all these factors have to be kept in mind, and you have to, planning is what is very important, and just don't focus on correcting the angle of deviation, but then focus on what is best for that patient and what is good in your hands. Thank you.